This is Ian Bodford.
And Liang Liu.
And welcome back to the Clinical Correlation. Today's case is...
I should start this case by warning you that this case is fictional and may have been inspired by a recent vacation.
A 29-year-old female presents to your ED with a headache and shortness of breath. She lives in Dallas and is visiting Denver for the week.
So in the morning, she starts at an altitude of 430 feet in Dallas, boards a plane, and lands in Denver, the mile-high city, with an altitude of 5,130 feet.
She decides to then go on a hike up St. Mary's Glacier. She starts at an altitude of 10,428 feet at the start of her 1.5-mile hike.
And makes it to the top to find a frozen lake which has an elevation of 10,848 feet.
Let's talk about high-altitude illnesses. Acute mountain sickness, or AMS, reflects a lack of acclimatization, and susceptibility to the condition is not related to physical fitness.
AMS occurs in 40 to 50% of individuals who live at a low altitude and sleep at an altitude above 10,000 feet, and in approximately 25% of those sleeping above 8,000 feet.
It is associated with a headache plus nausea and/or vomiting, fatigue, lassitude, dizziness, and difficulty sleeping.
Symptoms usually occur within 6 to 12 hours of arrival at altitudes above 8,000 feet, and they can begin 1 to 24 hours after arrival. It does not occur after adjusting to a given altitude for 3 or more days.
Risk factors include previous AMS, rapid ascent, higher altitudes, and strenuous physical exertion.
A number of preventative strategies can help combat AMS.
If you live below 5,000 feet, avoid ascending rapidly. On the first night, avoid sleeping above 9,000 feet.
If you plan to travel above 9,800 feet, do not increase your sleeping altitude more than 1,600 feet per day as you go higher. Plan a day of rest for every 3,200 feet you ascend. On this rest day, do not overexert yourself.
Climb high and sleep low. Hike to a higher altitude during the day and return to a lower elevation to sleep at night. This will help you adjust to the altitude.
If you plan to ski, hike, or climb, do not overexert yourself during the first few days at altitude. Pacing yourself is very important.
Avoid alcohol and sleeping pills, especially as you are adjusting to the altitude in the first 2 days.
If slow ascent is not an option, or if you have had symptoms of high-altitude illness previously, consider taking preventative medications such as acetazolamide, which you can start taking the day before ascent and continue for 48 hours or until you reach the highest point of the trip.
It is a carbonic anhydrase inhibitor that causes a bicarbonate diuresis and metabolic acidosis. It increases the hypoxic ventilatory response, decreases CSF production, and may also have effects on the peripheral chemoreceptors.
Know that acetazolamide can temporarily cause carbonated drinks to taste unpleasant. It can also result in increased frequency, numbness or tingling in the hands or feet, nausea, drowsiness, or blurred vision. Acetazolamide is not recommended for pregnant women.
Dexamethasone can be used in patients allergic to acetazolamide. Ibuprofen and aspirin have been shown to prevent headaches associated with AMS and can be taken for quick ascent.
Life-threatening conditions associated with altitude include high-altitude cerebral edema and high-altitude pulmonary edema.
High-altitude cerebral edema, or HACE, occurs typically at elevations over 9,800 feet. Symptoms include severe headache, confusion, ataxia, drowsiness, stupor, and coma. Ataxia is the most sensitive sign and should be considered an indication for descent.
The exact mechanism is not entirely understood, though hypoxia-induced cerebral vasodilatation and alteration of permeability of the cerebral capillaries are likely the cause.
HACE is a medical emergency and descent is urgently needed.
Additional treatment includes oxygen, several hours of portable hyperbaric chamber, and dexamethasone, 8 to 10 milligrams PO for any signs of HACE, and 4 milligrams every 6 hours thereafter until descent.
Pictured here is a portable hyperbaric chamber. It is an inflatable pressure bag that a patient can be zipped into and the device inflated with a foot pump. This can be a temporizing measure until descent is possible.
High-altitude pulmonary edema, or HAPE, is the leading cause of death related to high altitude. It occurs with rapid ascent to altitudes above 8,200 feet. It occurs within the first 2 to 4 days of ascent to high altitudes and is characterized by decreased exercise capacity, dry cough, cyanosis, dyspnea at rest, and pink frothy sputum.
It is caused by hypoxia-induced pulmonary vasoconstriction with increases in pulmonary artery pressure. Diversion of flow to less constricted areas results in capillary leak, and hypoxia inhibits the reabsorption of alveolar fluid, likely resulting in the condition.
HAPE prevention is similar to that for AMS and HACE. Most important is slow ascent. Preventative medications are not recommended unless the individual has had a history of HAPE or the individual must ascend quickly.
The goal of management is to reduce pulmonary arterial pressure. Relieving hypoxemia is the most effective method of doing this, reversing capillary leak, and protecting the brain and other organs. Supplemental oxygen immediately increases PaO2 and reduces both the heart and respiratory rates.
Strenuous physical exertion and cold stress both elevate pulmonary arterial pressure and can exacerbate HAPE.
Descent to a medical facility is necessary given the rapidly progressing nature of HAPE.
Where supplemental oxygen is not available or descent is not possible, portable hyperbaric therapy is life-saving.
While not validated, the use of CPAP and even having the patient breathe through pursed lips have had anecdotal success and can be used as a temporizing measure.
A number of pharmacologic measures can be used to reduce pulmonary arterial pressure as well, including nifedipine and phosphodiesterase inhibitors, such as sildenafil and tadalafil. Salmeterol is also used to increase alveolar fluid clearance.
The Wilderness Medical Society Consensus Guidelines for the Prevention and Treatment of Acute Altitude Illness provides a handy reference for dosing and the use of these medications for altitude illness.
Other things to keep in mind with altitude is the effect on the individual's other comorbidities.
For patients with diabetes, blood glucose meters can give inaccurate results at high altitudes, and patients should be warned about this.
Patients with coronary artery disease and chronic lung disease should consult their physicians prior to travel to high altitudes and may need to bring supplemental oxygen on their travels.
Asthmatics do not have worsening symptoms with high altitude.
Patients with hemoglobin SS will need oxygen for travel above 7,000 feet, and even patients with sickle cell trait have altitude-related complications, such as splenic infarction, even at altitudes below 9,000 feet.
To summarize, beware of altitude effects at 8,000 feet, especially in the patient not yet acclimated.
Avoid symptoms of acute mountain sickness, high-altitude pulmonary edema, and high-altitude cerebral edema by ascending slowly.
A good rule of thumb for anyone climbing is to climb high but sleep low. To prevent the effects of altitude illness, do not increase sleep altitude by more than 1,600 feet per day.
Keep in mind the effects that altitude can have on pre-existing comorbidities. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me @EMLLou.
Thanks for listening.